Good afternoon you all. I am Dr. Sanjita Das, working as Professor, Head of the Department Pharmacology at NIT Pharmacy Institute, Greater Noida. I am here today to elaborate about drug therapeutic monitoring. So, this drug therapeutic monitoring, it is a part of pharmacy practice, and you will know about why we need the drug therapeutic monitoring and what are the requirement and how it can be done. So, let us start with what is this therapeutic drug monitoring. Let us know. Therapeutic drug monitoring is generally defined as the clinical laboratory measurement of a chemical parameter that with appropriate medical interpretation will directly influence drug prescribing procedures, right. So, it is the mainly it is for the proper drug prescription and proper therapy means proper treatment of the patient, and this therapeutic drug monitoring, it is the clinically laboratory measurement. That means, we have to take the plasma and we have to detect how much amount of that drug is in the plasma, and that is mainly it will be monitored. That therapeutic monitoring is essential for the drugs where the efficacy is dependent on this TDM, and this therapeutic drug monitoring involves the use of drug concentration measurement in body fluids as an aid to the management of drug therapy for the cure, alleviation and prevention of disease. So, mainly we know that drugs have been taken for the cure, alleviation or prevention of disease, right. So, that can be evaluated, that can be monitored by taking the or evaluating the drug concentration, measuring the drug concentration in mainly body fluids like plasma I told you, and urine, right. So, this TDM enables the assessment of the efficacy and safety. Main target of TDM is, you should always know, the main target of this TDM is, that is efficacy and safety of the medication, particular medication. So, the goal of this process is to individualize therapeutic regimens of optimal patient benefit, that is individualize therapeutic regimens for optimal patient benefits. It is totally for proper patient care and proper patient benefit. So, what are the concept of therapeutic drug monitoring? So, this we should know about the concept. What is the main concept? That is, this TDM is based on the principle that for some drugs there is a close relationship between the plasma level of the drug and its clinical effect, right. So, it is the main principle. For some drugs there is a close relationship between the plasma level of the drug and clinical effect. When the plasma level decreases, the clinical effect decreases. Likewise, it is totally linked, and if such a relationship does not exist, then therapeutic drug monitoring is of little value. If there is no link between the plasma level, and it is very rare, right. And so, for those types of, if this relationship is not existing in some that is drugs or some types of medicines, so it is no, TDM is little value. Okay. The clinical value of plasma level monitoring depends on how precisely the treatment outcome can be defined, right. And when a precise therapeutic endpoint is difficult to define, right, when a precise therapeutic endpoint is difficult to define, monitoring of drug level may be of considerable therapeutic assistance. In these cases, it is very much required. So, this is this graph, this here you can see it is the serum concentration and it is the half life, right. And here in this graph the therapeutic range or therapeutic window is the, what is therapeutic window? It is the therapeutic range or therapeutic window, right. So, therapeutic range or therapeutic window is the concentration, right, range, is not it? It is the concentration range, okay, of the drug in plasma where the drug has been shown to be efficacious without causing toxic effects in most people. This is the toxic range. Here, from here the toxic range starts and from here the therapeutic effect starts. So, this is the concentration, therapeutic range or therapeutic window is the concentration range of drug in plasma where the drug has been shown to be efficacious without causing toxic effects in most people. So, the target concentration and therapeutic range. We should know about what is the target concentration and therapeutic range. The therapeutic range, I told you, there is mainly the concept, mainly this concept of therapeutic range suffers from two strategies deficiency. What are the two strategic deficiencies? First is the idea of the range introduced uncertainty into exactly how the prescribe the desired dose. Okay. So, the first thing, what is that? The idea of range introduces uncertainty into exactly how to prescribe the prescribed dose. And second thing is that deficiency, the second deficiency, what is this? Is the implicit assumption that all concentrations within the range are equally desirable, right. So, on the other hand, the target concentration is directly linked to a specific dose for an individual, not a range of the dose, right, not a range of doses. Selection of a target concentration requires an understanding of the concentration effect relationship, right, that is the pharmacodynamics of desired and undesired effects. We need to analyze, right, desired and undesired effects. The target concentrations for that is chosen to optimal the balance between the these effects desired and undesired. So, the selection of a target concentration requires an understanding of the concentration effect relationship. It is essential, that is the pharmacodynamic effects, okay, and the undesired effects. Pharmacodynamic effect is the desired effect and the undesired effect is the toxicity, right. So, different steps involved in target concentration strategy. What are the different steps in target concentration strategy? First step is select a target concentration, right. We are selecting suppose 10 mg or like this or there is target concentration like 100 microgram like this, right, and predict the clearance and volume of the what, that is the distribution, that is volume of distribution values for the patient based on population pharmacokinetic parameters and observational individual characteristics. Observational individual characteristic, it may be weight, it may be renal function, okay, and calculate the loading dose and maintenance dose rate to achieve the target concentration. So, administer the doses and measure drug concentration. So, that is the fourth step. I have to, that means the drug has to be administered and the drug concentration is to be measured. Use the measured concentrations to predict individualized value of the clearance and volume of distribution of the patient. So, we have to use the measured concentrations to predict what, the individualized value of the clearance and the volume of distribution of the patient. So, in if appropriate, revise the target concentration of the individual based on the clinical assessment. Then again we have to go to the third step, that is calculate the loading dose and maintenance dose, likewise it will go on, right. So, all these steps are involved in the target concentration strategy. So, all these have to be followed. Then therapeutic drug monitoring indications. What are the indications of therapeutic drug monitoring? Where it is very much essential, as from the very beginning I told you that it is required for some of the medications. So, where it is indicated, let us know. Drugs for which relationship between dose and plasma concentration is unpredictable, right. So, in that case it is indicated like phenytoin. Drugs with a narrow therapeutic window, right. Narrow therapeutic window will allow dosage alterations to produce optimal therapeutic effect or to avoid toxic effects. For example, lithium phenytoin, it is one example, it is best example, and digoxin also it is one example having narrow therapeutic window which allow dosage alternation to produce optimal therapeutic effect. The next thing is drugs with steep dose response curve like theophylline, it is having steep dose response curve. For that also their therapeutic monitoring can be used. Then drugs for which there is difficulty in measuring or interpreting the clinical evidence of therapeutic or toxic effects like nausea, vomiting occurs in both digitalis toxicity as well as congestive heart failure. So, if the therapeutic toxicity toxic effect it is that is to differentiate, it is difficult to the that is disease and the drug. So, here also the therapeutic drug monitoring is essential. Then drug with saturable metabolism like phenytoin, right. Drug, if drug is having some saturable metabolism like phenytoin, it is also one indication for this TDM. Then drugs with poorly defined endpoint or difficult to clinically predict the response. For example, immunosuppressant drugs, it is very difficult to predict the response. So, if the clinical prediction of predicting the response is difficult, then also the therapeutic drug monitoring is essential. And for renal diseases, after that is alter the response relationship between dose and the plasma concentration, it is important in case of digoxin, lithium and aminoglycoside antibiotics. So, next thing where it is indicated this TDM, that is the drug interactions. When another drug alters the relationship between the dose and plasma concentration, like plasma concentration of lithium is increased by thiazide, right. If by any means, by any pharmacokinetic drug interactions, if the drug concentration of one drug or the dose of plasma concentration of one drug gets deviated by another one. So, here also the drug therapeutic monitoring is essential. Then next is drug with the large individual variability. At steady state PDC in any given dose, it is also the drug with large individual variability, it requires the therapeutic drug monitoring because individually it is to be monitored. Then for diagnosis of suspected toxicity and determining the drug abuse, in that case also it is required, right. And to evaluate compliance of patient, what is the compliance of patient? It is also required for those type of cases. Then guiding withdrawal of therapy like antiepileptics, cyclosporin, if withdrawal therapy is to be guided, then also the therapeutic drug monitoring is required. So, the drugs which are suitable for TDM, let us know about the drugs which are suitable for TDM. The drugs having wide therapeutic index, so these are not suitable, right. Sorry, I am saying you about the drugs because we knew about what are the indications, right. Till now we knew about what are the indications where the therapeutic drug monitoring is required. वहाँ पे क्या था? So, it was there that narrow therapeutic index, but where this TDM is not required, where we are not requiring the therapeutic drug monitoring and where this therapeutic drug monitoring are not suitable. Let us know those things. So, those drugs having wide therapeutic index also the therapeutic drug monitoring is not suitable, right. And next is the toxicity is not a realistic concern like penicillin. The toxicity is not a realistic concern. In that case, it is not suitable to go for TDM, right. And the effects can be measured using functional laboratory test, right. In that case also like anticoagulants, in that case also the TDM for that is going for TDM is not suitable, and effect of relationship remains undefined. If the effect of relationship remains undefined like antidepressants, the that is it is not defined, you cannot define the effect. In that case also the drugs that are not suitable, these are coming under the drugs which are not suitable for TDM, TDM is not suitable to analyze, right. Then hit and run drugs like omeprazole, MAO inhibitors, these are coming under hit and run drugs. So, for these also there is less requirement of all these TDM. So, now let us know what are the basic principles of therapeutic drug monitoring. So, there are some points, some important considerations, right, to ensure an optimum therapeutic drug monitoring service in any setting. So, what are those? Let us discuss. Measurement of patient's serum or plasma drug concentration taken at appropriate time after drug administration. That is the first important consideration. Next important consideration is knowledge of pharmacological and pharmacokinetic profiles of the administered drug. So, that is also essential. Knowledge of pharmacological and pharmacokinetic profile of the administered drug. What for this drug? What is the pharmacological effect and what is the mechanism and what is the pharmacokinetic profile? All these are different important aspects, and these profiles of the administered drug, the knowledge is essential. So, that is the second prime. And the third one is knowledge of relevant patient's profile like demographic data, clinical status, laboratory and other clinical investigations, right. And the last one is interpretation of SDC after taking into consideration all of the above informations, right. So, and individualizing the drug regimen according to the need of the patient. So, for all these four are the basic principles of therapeutic drug monitoring. So, what are the process behind this therapeutic drug monitoring? Let us know about the process. The development of there is plasma profile in each patient. Okay? The development of plasma profile in each patient, it is the one thing, and administering a predetermined dose of the drug is required. Then what will be the next step? That is collection of the blood sample, in which we will check the drug concentration, right. And next is determination of the blood sample. We will go for analyzing, we go for determining the drug blood sample where the drug is there, right. And the plasma profile and pharmacokinetic model development. So, it is the next process of therapeutic drug monitoring. That is the clinical effect of the drug, it is to be evaluated, development of dosage regimen, right, diagnostic and dosage form selection, dosage regimen and initiation of therapy. So, all these are for evaluation of clinical response, how much efficacious the drug is, how much it is affecting to the disease treatment, for the disease treatment. So, all these are many all these are very much essential for therapeutic drug monitoring, and it is these are the processes involved in the therapeutic drug monitoring. So, next is about the samples on which we can go for checking the therapeutic that is going for the therapeutic drug monitoring. The sample selection must include appropriate matrix, right. It is very much essential. The plasma or serum is commonly used in the drug assays. Whole blood sometimes taken for the like cyclosporine, tacrolimus, sirolimus, for all these we are taking the whole blood. Then saliva, which gives a measure of the unbound drug concentration, for example, phenytoin, lithium, amitriptyline. Okay. So, saliva can also be used as the sample. So, before collecting the sample, what are the different aspects to be considered, right? Let us know. Establish that HDC is at steady state. We have to establish first. The next is ensure complete absorption and distribution. The drug has to be completely absorbed and distributed, right? Then samples should be collected and centrifuged as soon as possible. It should be the time, if we will give some time for that is sample collection, and then you will keep it, and then after some time or after some days you will centrifuge, it will not give the appropriate result. Avoid serum separator tubes. Storage of sample is very much essential in mainly plastic cryovial type of tubes are used, and for CSA the whole blood to be collected in EDTA tube, and analytical methods should be stabilized. That means, all the analytic, if we are going for titration or if we are going for any that is spectrophotometric method, those analytical methods should be standardized. Without that we cannot go for the TDM. So, what are the guidelines to specimen collection? First thing is, draw blood used for the TDM demonstrates a drug action in a body at any specific time when definite data are required. For adequate absorption and accurate therapeutic level, allow for sufficient time to pass between the administration of the medication and the collection of the blood sample, because we need it to be totally absorbed and distributed. It is coming under the principle. Then blood specimen for drug monitoring can be taken at two different times, during the drug's highest therapeutic concentration or its lowest therapeutic concentration. So, one is peak level, another one is trough level. So, we have to collect it. Then occasionally called the residual levels, that is trough levels, which show the what? The sufficient therapeutic levels, whereas the peak levels show the that is mainly these are that is occasionally we are calling it as a trough level shows sufficient level, and peak level shows that is less therapeutic levels. Then these peak and trough levels, these two peak and trough levels, that is should fall within the therapeutic range, because we have already discussed that therapeutic range, for therapeutic range, if it is narrow therapeutic range we are going for TDM, and the here the trough is showing the sufficient therapeutic level, whereas the peak is showing the toxic level, toxicities, right. So, guidelines to specimen collection. First is the patient receiving a drug at a dosing interval, right, longer than the half life of the drug will show large fluctuation between the peak and the trough level. So, we have to avoid this, right. Then plasma concentrations of the drugs dosed at intervals shorter than the half lives would show less fluctuation between the peak and trough levels. And for the chronically administered oral medications, the peak levels usually occur 1 to 2 hours after the dose, okay, and trough serum concentrations shortly after the dose is administered. Then if we are considering digoxin is one of the exception the serum level to determine peak activity should be drawn after the serum that is digoxin has had time to equilibrate with the tissue, right, 6 to 10 hours after the oral dose. So, other guidelines for specimen collection like intravenous medications should also be given time to equilibrate before the peak level is drawn, right, and medications that can poorly soluble at body pH, however, may precipitate at the site of injection and achieve very low and late peak serum levels. So, the next guideline for specimen collection is the clinician should know what questions are to be answered by the sample. What are the things you need to know being drawn, as different questions may require different sampling types and possibly different numbers of samples. So, for patients suspected for symptoms of drug toxicity, we have to go for when the symptoms are occurring, we have to take the samples. Then timing of specimen collection, it is also important. The best sampling time is in the pre-dose or trough phase, right, when a drug is administered by multiple oral doses. Then the correct sample time should also be taken into account adsorption total, that means absorption and distribution should be proper, like digoxin sample are collected after 6 hours of administration. After 6 hours the absorption and distribution is totally done for it is there for digoxin. So, we are taking it. Then for short half life drugs, more than one sample, right, 3 in is ideal, is to be taken, most useful for that is determining the individual pharmacokinetic parameters. And for long half life drugs, a single sample during the that is dosing intervals is sufficient, like cyclosporin, a single trough is sample is enough. Then the sample concentration. So, sample concentration, some are lower than the anticipated, some are higher than the anticipated. Lower than anticipated include the patient's non-compliance will get lower than anticipated, error in doses regimen, then we will get the lower than anticipated rapid elimination, that is changing hepatic blood flow, poor viability, if it is reduced plasma binding, all these are the causes of lower than anticipated. And higher than anticipated, error in dosage regimen, rapid bioavailability, then we will get that is higher than anticipated concentration, sample concentration, is not it, and slow elimination. If elimination is very slow, then we will obviously get the sample concentration higher than the anticipated, and increased plasma protein binding, then also we will get, and decreased renal and hepatic functions. Then these are the factors affecting the results like pharmacokinetic effects, pharmacodynamic, dose, sampling time and type, testing methodology, right, and genetic polymorphism and other variables like smoking, drug formulation, right, and interactions with other agents. Then these are the major sources of pharmacokinetic variables like patient compliance, age, physiology, disease, drug and environmental influences. So, we have to consider all these factors, that is protein binding, how it is influencing the TDM, and active metabolites. If there is active metabolite, it will also affect the TDM, and pharmacokinetic parameters which are important, that is bioavailability, volume of distribution and distribution phase, clearance, half life, protein binding of drug. These are to be included in this case, and HPLC, LC, GC, EIA, RIA, these are different that is techniques which are used for TDM. And clinical significance of TDM, maximize efficacy, it will avoid toxicity, is not it, identifies the therapeutic failure and facilitates the adjustment of dosage, facilitates the therapeutic effect of drug and identify the poisoning. So, all these are beneficial, these therapeutic drug monitoring, it is very much beneficial mainly for the that is narrow therapeutic index drugs and for the patient care and for better treatment and for better efficacy. So, thank you so much.